Welcome, everyone. This is Ann Cuppinger, and I'm here with Boris Vilgorin from the Managed Care Technical Assistance Center, and we want to welcome everyone to this afternoon's webinar on understanding paper claim submission. We're really glad that you were able to join us and hope everyone had a nice holiday weekend. Before we get started, I want to cover a few housekeeping matters. First of all, everyone is participating today in listen-only mode. That's just because we have a lot of participants. So we want you to be able to chat the questions in that you have throughout the webinar. The way that you do that is to open up the chat box, which may be open on the right-hand side of your screen now. And if it's not, you can click on the speech bubble icon that you'll get when you hover over the bottom of your screen. And you can chat your questions in, and we'll take as many questions as we have time this afternoon. It's somewhat of a lengthy webinar, but we'll do what we can to answer your questions. Also in the chat box, Brad has posted a PDF, a link to a PDF of the UBO4 billing form. You might find it helpful as you listen to today's webinar to be able to reference that form. So we provided you with a link so that you can print that out. And as always, the slides and the recording from the webinar will be posted on our website within a few days. And just a reminder that all of this information and timelines are current as of today. And in reference to any kind of billing conversation, we really encourage you to always refer to official state guidance and documents for official information. So with that, here's our agenda for today. We're going to just quickly go over some billing basics, a recap on some revenue cycle management concepts, and a little detail on the mechanics of submitting a paper claim. Then the bulk of our time will be spent doing a walkthrough of the UBO4 claim form, which is the standard form that you'll be using to submit a claim, the same form that you would use whether you're submitting a paper claim or an electronic claim. We'll also talk about some troubleshooting, some common issues that people find they encounter as they're managing claims. We'll share some resources with you and hopefully have time for a few questions. So there are a number of ways that one can submit a claim. And we were asked to do this webinar primarily by providers who have limited experience submitting claims or whose volume of claim submission has led them to think that it might be best for them to do a manual paper claim submission process, at least as they start out. There are many other webinars that are posted on the CTAC website that go over various aspects of billing and revenue cycle management, some general, some in relationship to specific types of service. And we would really encourage you to refer to those as well as state guidance documents for more details. But in addition to actually submitting a paper claim where you fill out a paper form and either fax or mail it to the managed care plan, you also have the option to submit claims through a Medicaid managed care plan's portal. And that's something that you'd want to talk with each of the plans that you're contracted with about how their portals work. It's sort of a little bit of a step ahead of submitting paper claims in terms of its ease for you, but each plan operates those portals a little bit differently, but it's something you might want to look into. You also have another option which is short of developing a full electronic health record, and that is to use a billing system in coordination with Clearinghouse. So we're not going to go into detail on all of those, but it's just really, we're just mentioning it to make you aware of the fact that this is a really reasonable way to start in terms of submitting claims to use paper or portal, but that you have some other options going forward. And if you get to where you're thinking about electronic claiming options or an EHR, you always have the option to build a system for your organization or to pay for a service that could handle the billing for you, kind of on a claim-by-claim basis. And you also have the option to get together with other providers and kind of build a collaborative back office function, sometimes called service organization. Some people do it through other mechanisms. But it would be a way for multiple smaller providers to say, this isn't something that we want to do are on our own, but we want to share some of the overhead costs associated with billing. So a few things that you'll want to consider as you're deciding whether it's the right path for you to use paper claims is to first look at the volume of claims that you're going to be submitting. If that volume is low and manageable for you, that's great. It's something you might want to monitor, how much staff time it's taking and how it's working for you as the volume of claims increases. Payment generally takes longer when you submit claims in a paper format. There are required timeframes for the plans to pay you. For paper claims, it's 45 days. For electronic claims, it's 30 days. So it will take a little bit longer, and obviously if those claims are correct, that goes more smoothly and is quicker. If you have to be correcting errors, it'll take a little bit longer. Regardless of how you decide to submit claims, you have the option to receive payment electronically. So even if you submit claims, paper claims, you can still sign up with the plan to receive payment electronically and also to receive regular reports from the plan about claim status electronically. The other thing you'll want to consider is, the actual submission of the bill is one piece of an entire process, and that includes everything from scheduling to checking your client's eligibility and monitoring claim status. So you're going to want to think about how all of those other functions will take place, kind of surrounding the actual submission of the claim. A few other things, this is information that you've heard before on various webinars. This is kind of a checklist just to be sure you're ready to submit any claims at all, and that is that you have to be a designated provider, you have to be enrolled with Medicaid, your staff have to have NPI numbers, you have to be contracted and credentialed with any of the plans whose members you serve, and you'll want to do a really careful review of the service and billing manuals for the services that you're providing, and have a conversation with the plans that you're contracted with about, their suggestions around the claims process. A few other things that you can do to prepare is really to develop a team. This isn't a function that really lives only in your finance office, but it involves truly collaborative work and communication between everyone in the organization. That's true for large organizations, but it's also true for small organizations. Getting claims right is everyone's responsibility. And you'll want to put together a team that kind of maps out what the process is going to look like for your organization, but also that meets very often in the beginning and still fairly often as things get rolling to monitor the process and to be sure that everything is working as planned so that it goes smoothly. Yes, and as a part of that, sort of developing plans for internal and external communications around the revenue cycle. You're also going to want to work with your finance person or finance team to be sure that your financial system is set up to handle billing for managed care and create workflows and timelines and very clear responsibilities for how the claim is going to be handled throughout its cycle within your organization. And within that workflow, be sure that there are points in time where you're pausing to really be sure that the quality issues are being addressed. Is the service that's being provided a service that is within the scope of the provider's practice? Is the documentation accurate? Does the documentation line up with the treatment plan and the recommendation or referral that the child has in order to receive the service? And, are those aspects of the service delivery and documentation lining up with how you're billing for that service, as well as a number of other steps along the way that you want to build in so that you're sort of double checking the claim as it moves along to be sure that it's going to sail through as a clean claim. And lots of training and support for your staff around this. So that's something you'll want to be talking with supervisors about, how they can really help, especially in the beginning if this is something that's new for you, to be sure staff are really knowledgeable about the process. And with that, I'm going to turn this over to Boris. who's going to take us through some reminders around revenue cycle management.
Excellent. Thank you, Ann. Thank you for the overview and introductions. And again, just want to remind folks that please feel free to chat your questions in throughout the presentation, and we'll try to get to as many of the questions as possible. As Ann mentioned, there is quite a few elements that we want to cover today. The biggest one being really going through the form, which really requires us to go through quite a few fields on the form. But before we get there, and to kind of highlight the training for your staff and the team approach is really encompassed in this term revenue cycle management. And I think, again, at the end of the day, as Ann already mentioned, revenue billing, and all components are really responsibility of all staff and not just finance. I just wanted to underscore Ann's point. And when we talk about, kind of the revenue cycle component, it does require a team approach. It does require administrative, clinical, and all come together, because at the end of the day, billing is generated based on information that's inputted or captured either on paper, because somebody writes it in, or electronically by staff who are providing services or administrative staff who are registering clients, and so forth. So that information and accuracy of that information drives the ability to generate bills, submit bills, and then get paid in a timely fashion. One of the things you hear a lot is something referred to as the clean claim. And again, what that is a reference is that all appropriate fields are completed. They're completed in the right way with the right information, and which then allows both Medicaid and or managed care company to pay the provider. The other piece that I just wanted to mention, we will focus a lot on managed care billing, but I do want to also underscore that some of you will need to bill Medicaid directly as well. And so through the ePACES system, you also have the portal capability, just like managed care, if you need to bill Medicaid directly in those instances. So kind of some of the similar processes exist both in managed care and fee-for-service when we get to this. But coming back to the revenue cycle management or revenue cycle, again, it's really a description of, from the beginning, meaning the moment you register somebody with your organization, your services, to the time you get paid. Or not, and you have to do some research of what's happening with that claim with that service. The goal here, as was mentioned, is a team approach. It brings together a work group of all staff, as we talked, and it's the revenue generation becomes and is the cornerstone of your fiscal viability, right? Making sure that that you get paid for every service that you provide. And of course, what you want to do is prevent or at least reduce dramatically the inefficiencies, errors. You want to increase oversight, which can help with everything, in regards to it. So this work group and this team, their job is to really make sure that every service is accounted for and you know exactly where in the cycle it is. And if there's things that are getting stuck or not getting paid that you're aware of, and you move towards fixing those, either it's inefficiencies or errors or some other issues that might be identified. And again, you want to align the service part with your fiscal and billing priorities and move in the same direction. This is another way to illustrate revenue cycle management in different phases that it has. Prior to service, as I talked about, kind of the registration piece of the individual, of course, information that gets captured during the services provided. Then things happen afterwards. Post-services, you're submitting claims, and there's always ongoing. The big piece is really the analysis of the whole claim submission. So again, another way of looking at it. But the key here is, again, having the team and having a process that oversees this and tracks it. One of the things we've done over the years is we've talked to managed care and got their input on kind of what their big takeaways are and what they would recommend for successful revenue cycle management. As you can see, number one is train staff. Not only staff that know how to complete the form, but also, again, other staff that might be providing information if they're not even completing the form directly. And when I say the form, I mean UBO4 billing form. Want to make sure that it's always HIPAA compliant and meets all the HIPAA requirements. And talked about how quickly the managed care has to pay, but there's also a part on your end of how quickly you have to submit claims. So it's called a timely filing deadline. You have at least up to 90 days to submit claims, and that was a state kind of mandate to the managed care organizations. So that should still be, within your contract indicated. Some plans might give you a little bit more than 90 days, but you do have to make sure that when you generate bills, that you meet those timely filings. You also have to be responsive to when you get either denials or other errors that come back from the managed care organization. You want to make sure you're on top of it and you make prompt corrections and resubmit those claims. And as was mentioned, if you choose to, and we strongly recommend to get electronic payment and statements from the plan. So at least when you receive it, you can still receive information back in electronic format. So the other component before we move towards really going through each of the kind of fields and how to complete the form, and I know Ann alluded to this and mentioned it in one of the slides, is really confirming eligibility. So what you want to do is before you bill a managed care organization or Medicaid, you want to make sure to check the eligibility of the individual you're serving to make sure that they're, one, still eligible with Medicaid, that they didn't lose their coverage, and two, that you're billing the right Medicaid managed care plan at that time. And so one way to do this is you always want to ask for the Medicaid card. You also want to ask if they do have Medicaid managed care for their Medicaid managed care card, just like any doctor or healthcare provider will ask you. When you show up, they usually ask for your insurance card. You should be doing exactly the same thing and making photocopies of the front and the back. However, that still doesn't mean just by asking for the card that the individual is eligible, because we all know just because you have an insurance card doesn't mean you're actually active with that insurance. So the way you check that is through ePaces, and that's really one of the best ways to do that. And you can also always talk to the Medicaid managed care plan to confirm eligibility. And the communication with Medicaid managed care is crucial on many levels, not just to confirm eligibility, but also to make sure that nobody else is providing the services you're providing. Make sure that Medicaid managed care might have other information that might benefit you in providing services to the individual. So, my recommendation has always been irrelevant if you need authorization or you don't. And of course, if you do, you definitely need to call the plan. But you should be always in communication with the plan, making sure they're aware of that you're starting treatment, and any information that might be helpful for you, you can obtain from them. If you're not familiar with ePaces, again, it's really an acronym for an electronic system. It's really the Medicaid system that provides you information, again, on eligibility. We also provide some resource here on how to enroll in ePaces and be able to access that. In the process, it varies from time to time, but some instances it could be pretty quick. And it's only available to Medicaid providers. That's another reason you want to make sure you're a Medicaid provider. I mean, it's a requirement anyway, but that also gives you that benefit to be able to look up eligibility through ePaces on that. So with that kind of preset and overview when I jump into the form. This is just a snapshot, really half of the form or so. And what we'll do is really go field by field, going through this form again. As paper, you can submit it through secure faxing, as was mentioned already, mail, or you can go through the portal of each managed care company. Now, they might not refer to their system as portal all the time, but you might want to have a discussion with them on how you can submit claims by logging into their system, and they'll walk you through that. So here's the walkthrough the form. So we'll start with field 1 and go through. Some of this will go really quickly, and some I'll pause because some of the particular fields really historically and recently seems to cause the most problems and denials and providers getting a little bit stuck in. So I'll pause and go through, spend a little more time in some fields versus others, especially the ones that are self-explanatory. Yes, Ed?
Yeah, Boris, I just want to jump in here for anyone who signed on a little bit later. There is a link to the form that Boris is going to be walking everyone through in the chat box. So you can actually pull that up and look at the form as you're hearing about each of these fields.
Excellent. Yeah, thank you. Thank you for that reminder. I also want to mention that this is a part of our billing tool that's available on the MCTAC website. It's an interactive tool, and it really has been put together in partnership with all the Medicaid managed care plans. And what we try to do is work with them to, one, find out if they have any nuances in a particular field. So you as a provider know that sometimes for a particular plan, you might need to do something different, and you'll see this as we go through some of these fields. So this is really in partnership, not just with the state as we do all of our material, but also with Medicaid managed care plans throughout the state. So with that, let's jump right into it. So field 1 is a required field. It's your information as a provider, and of course you should complete it with your name, address, and so forth, as indicated here. Field 2, it's not really required with some of the exceptions of WellCare, United, Implement. We kind of list those exceptions. And so what you want to do is indicate the billing designation, meaning where would the kind of the billing provider information go to. Sometimes it might be the same, sometimes it might be different as your other information. Field 3 is referred to as a patient control number. And it's really meant to be predominantly for the electronic health record component. It is required that you populate something. Usually, if you do have an electronic system, it would generate an electronic number that's specific to that case within that system, and that's where that number goes in. It also might be referred to sometimes as the medical record number in a lot of instances. And so what that helps is really for the tracking purposes. This is one of many ways you can track who you're talking about with your own particular system and your number as you kind of go through this. Field 4 is the first field where I'll pause and spend a little bit of time because this is where a number of issues continuously come up, and from what we understand, still continue. And so field 4 is a type of bill. It has 4 digits that you have to complete. The first digit is very simple. You just put 0. And so everybody puts 0 to kind of, it's a kind of filler, if you will. The second digit is, and we'll go through second, third, and fourth in its specificity with the next fields. It identifies the type of a facility you are or provider. The third digit dives in deeper a little bit. And the facility, a type of care, and the fourth digit is the sequence of this bill. And it is required, and it is very important that it's completed correctly. So as I mentioned, first digit is 0. The second digit, in regards to type of facility, these are federal designations, if you will. So a lot of times, unfortunately, they don't fit perfectly to identify exactly who you might be in regards to an organization or program. But if any of these does fit you, perfectly, that's great. You should be selecting that. I think for behavioral health providers, a lot of times what they would choose is number 7 as kind of to fill the second digit in regards to, out of all the choices you have here as the best fit. But again, you should really be taking a look, trying to match the best description of the facility. When you get to the third digit, it would be important, as how it relates to the second digit, right, that you just completed. And I'll just jump past this because these choices would not apply to you if you selected 7. And again, let me just go back for a moment. So 7 indicates it's a clinic or hospital-based dialysis facility and so forth. So the third digit here will apply for inpatient, of course, and other types of facilities except for clinics. If you do select 7 as your choice, you would then have this option to choose your third digit. These would be the choices you have here. Again, there is clearly, as you can look at it, limited number that fits behavioral health providers. So a lot of folks will pick 7 in a way to indicate as close as possible to your affiliation with this. If you're an FQHC, that's great. You can pick 3 and so forth. But again, recognizing that these are federal codes and federal choices, you're kind of trying to pick the best one that fits yours. So that's really your second and third digit. The last digit, which is the fourth digit really on the right-hand side of this slide, really indicates the claim sequence. And for most providers that are outpatient providers, we really are talking about number 2, the first claim, or number 7, a replacement claim. Those are the 2 most popular or most highly used. So if you're submitting the claim for the first time, a lot of times providers would choose 2 to indicate this is your first claim. And if you're rebilling, either because you had a denial or there was an error or the managed care plan asked you to rebill, you really should be using number 7 in that instance. One of the biggest mistakes providers have is they continuously put number 2 in this digit. And what happens if you continuously put 2 on the same claim and you're rebilling or replacing, as this might refer to, you would get a denial saying this claim has already been processed. Because as far as managed care plan is concerned, this is no longer a first claim, it's a replacement. So what you want to make sure you're really indicating that you're rebilling, if that's what you're doing, and using the appropriate digits. And of course, if you're voiding because maybe you submitted it inappropriately or incorrectly altogether, or you need to cancel the claim, you really should use digit 8 to indicate that's what you're doing. So again, between the second, third, and fourth digits, very important that you pay close attention. And the other option I tell providers when it comes to the second and third digit to kind of identify the facility and kind of the services you provide is to have a conversation with the managed care organization to also see how you are loaded in their system to match what you're billing and have that discussion. And make sure that what they have loaded you in, if they did load you as a clinic and so forth, that you're billing appropriately. And if they haven't, to have the discussion that you're indicated properly. Because if there's a mismatch, that's another reason why a claim might be denied. Because if you're billing as a clinic and for whatever reason they have you indicated as a hospital, that would be a mismatch and a potential denial and a delay of payment. So you really want to be, again, in communication with the managed care organization to make sure, those kind of numbers and codes line up appropriately. Moving on through field 5, it's your federal tax ID number, so make sure you populate that and use a hyphen in the field. Field 6 is a statement covered period from through. It is required, again, for all major billing. It's really required when you have a monthly rates. And so we have very specific indication for the statement covered period here in regards to from box and through box. And in some instances, it may contain the same date because you are billing just the same date of service, right? So if it's one date of service, the date could be the same from the beginning and through. But it is a required field, so please make sure you complete that. Field 7 is not required, so there's no need to complete that field. Field 8, that's where you would indicate the patient's name. So, of course, that's required. Field 9, only the A is really required, the patient's address, street specifically. You really don't need to complete the rest of the information. If you do, it shouldn't be a problem, but make sure that at least the patient's address, which is street, is completed. Patient's birthday is required, and so we also provide the format that you should be putting that in, and so that's an important field. Including their gender is also a required field. Admission date is really not required except from emblem, which is for the downstate providers really, but otherwise admission dates are not required. Same thing for the hour, which is field 13, or prior type of admission. So a number of these fields are not required. What we recommend is you do talk to Emblem if you do have that in Excelis to kind of discuss with them directly on what they would be expecting from you in these particular fields. But for everybody else, it's really not required. Same thing for point of origin for admission. We have a couple of additional plans that do require this in regards to this particular field. So it's important to pay attention to that. Discharge hour, same thing, not required except from emblem as with some of the other ones. And patient discharge status is important. Again, it's not required with some exceptions like WellCare, Empower, Blue Cross Blue Shield, Health Plus, and so forth. Some of the common codes that you might use in this particular instance is 01. If you're discharging to home or self-care, or you can indicate 30 if the patient is still in treatment and so forth. So this is the discharge status, field 17. Field 18 through 28 is not required, but again, please note for WellCare that there is some requirement, especially if it's related to inpatient. So if you do have a contract with WellCare and billing WellCare, please make sure you pay attention to that, and they do provide a code that you might utilize in this particular field. Field 29 is not required except from emblem again. Field 30, 31, 32, 33, and 34 are not required for all, so that's easy. 35 and 36 is the occurrence span code. Again, not required except from emblem under certain situational conditions. 37 and 38, not required. 39, another area where I'll pause for a moment. It is required. It is a value code, as it's known, and that's really the one we're going to focus on. The way you complete this field is by entering 24, followed by the rate code. So every bill, and we'll get to the rate code, has a rate code associated. The way value code is created is you add 24 in front of it. So please make sure you do complete this appropriately and use the appropriate 4-digit rate code that's associated with it. There are some nuances, as I've mentioned, as we worked with a number of plans that also require that you put a 00, especially, if it's both paper or electronic, and in some instances it's only for paper version. So again, pay very close attention to this field and make sure it matches to the rate code you're submitting and the appropriate 0, 01 required for a particular plan. Moving on to 40 and 41, this is not required because this is really allowance for menu rate codes or menu value codes. But since in New York we're only allowed to and can use only one rate code per claim, these fields really would not be completed. 42 is the revenue codes. It is required. One of the things we do provide in our billing tool when you get to this field is the listing of potential revenue codes based on services you provide. So it's a chart that really breaks this down. So I would strongly recommend that you look into that and kind of match that appropriately as needed. Field 43 is really not required with exceptions of Excelis and Emblem. And again, I would recommend that you talk to them directly to get more information. Field 44 is one of those crucial required codes, which is where you indicate the CPT or HIPAA code, which is basically where you indicate the service you provided. And that is in the billing manuals that Ann referenced before and in many other presentations. So this is where it becomes important that you're using the right procedure codes to indicate the service, and also when appropriate, use the appropriate modifiers as well. And again, the billing manual has a lot of information on CPT codes and modifiers for services. So please make sure you reference that appropriately to complete this field. The service dates, of course, is required. That's when did you provide the service. The service units are required as well. And the total charges, meaning how much are you charging. It's important to indicate that. My recommendation is you put at least a minimum of the rate the Medicaid rate that is applicable to the service you provide. So again, this is an important field that you complete. Field 48 is not required. Field 49 is also not required. 50 is also not required since we're dealing with Medicaid in this particular instance only. Each individual has their own insurance, if you will. So from that perspective, Field 50 is not required, again, except for our Emblem, Excelis, and United. And so I would, discuss that with them directly. All right. Field 51, this is the health plan identification number. So I've mentioned before you should make a copy of the card that's provided, the plan card. This is where you would put that number for Excelis, for example, but overall it's not really required field. Field 52 as well, not required with some exception, as well as 53. 54 and 55 is not required for all. 56, another area where it's important to pause for a moment. This is actually pretty straightforward as an organization. Ann early on talked about staff sometimes having an NPI number, and we'll get to that in a moment. This is your agency NPI or your program, depending on how you have set up your NPI. But this is where you would put either the program or agency NPI number. 57, you would not need to complete, as well as 58, with some of the exceptions that are indicated here. 59 is not required at all. Field 60, it is required. Again, this is another area for the insured unique ID. So you want to put this either the Medicaid number or the insurance number that's provided by the insurance. You do not need to complete B and C. Those areas are not required except for Emblem. 60, 62, and 63 are not required. But again, those are authorization areas, but if one authorization is needed, make sure you're obtaining those as needed for that. So it's important to note that even though on the claim form, you do not need to put an authorization number for the billing purposes, it is important to make sure that for services that require authorization, that you obtain that. My recommendation has always been treat it as if it is a required field, because that will hopefully trigger some flags and pauses as needed, but technically to generate a bill or to bill a managed care company, that is not required. And for authorization requirements, please refer to the utilization management guidelines. 64 is not required as well, except for Excelis. 65 is not required. 66 is the diagnosis and the procedure code qualifier. Again, not required with some exceptions. 67 is required, and that's where the diagnostic code would go. Or you can also use R69, and that's a deferred diagnosis. That's usually used in your first visit when you're still trying to establish a diagnosis. But if you do have one, even in the first visit, that's totally appropriate to use a diagnosis code here. There is a caveat for United Healthcare. Please use F as in Frank 99 for mental disorder not otherwise specified instead of R69. But it's important that that field gets filled out. 68 is not required, as well as 69. 70 is not required. Again, as you can see, there's exceptions for some of the plans, so please pay attention to that when you reference this tool. 71 through 75 is not required for all. 76 is another important field that will pause. This is where we start putting the NPI number or unlicensed practitioner number in the area. So again, please refer to the requirements by the state from the billing manual. If an NPI is required, and under certain instances it is required, and please use that staff NPI. If it's not required, you can't use the OMH and OASIS, kind of the unlicensed practitioner. We do have a section for electronic piece, but since we're working really on a paper claim, you really don't need to worry about the bottom portion of this slide. 77 is not required in this area. 78 is another important field to kind of pay attention to, especially when we talk about children and family treatment services, as you can see. And so make sure that the right information, NPI, is included in this area as well, especially around children's services. And when we get to 79 is not required, as well as 80. 81 is also not required. Excelis and Emblem do have their own requirements here, so please note those for 81 as well. So I know I went through that, quite quickly, wanting to touch some, but we have a number of other webinars and areas that record that go through this. Again, the tool that we have goes through this, field by field. Like I said, it's interactive. So wanted to make sure we have some time that we talk about it. We do have some common errors and mistakes that folks make. I think the bigger ones that I just want to highlight is the eligibility piece that I talked about is important, because what we're learning is when you do need to bill Medicaid, sometimes folks still bill directly to managed care, or sometimes folks don't have Medicaid and you bill managed care or Medicaid directly. So you want to make sure you follow those, though. Invalid rate codes come up a lot, or procedure codes, so make sure you're using that billing manual a lot, and using the right rate codes and procedure codes, especially in the right combination, the way it's intended from the billing manual. And again, when there is authorization, that you're obtaining authorization as needed as well. So that's some of the pieces, in addition to some of the other errors we have here. And if things go wrong, you want to do some research, and you want to make sure you understand why you're not getting paid or you're getting denials, and collect that information. Review the manual, review what you're getting denied on. Is it consistent with denials? Is it the same error? Is it something on the managed care side? Then maybe managed care is making an error. It could be on either side, but please review the information from that perspective. So I think I'm going to turn this over back to Ann, that's going to go through the resources, and in the meantime, I will jump and see what questions might have come in, organize them, and then after Ann goes through the resources, I think the remaining 10 minutes or so, we'll try to answer as many questions as possible. So Ann?
That sounds great, Boris. Can you pass the baton back to me so I can advance?
There we go.
Thank you so much.
Yes.
Okay. All right. So that was a lot of information. So if you have questions, you can continue to chat those in, and we'll take a look at them. One of the things that we have here, and this is also in the, at least for the children's services in the billing manual, there are certain kinds of combinations of services that can and cannot be billed simultaneously. So it's important to be aware of what services your clients are receiving. We get a lot of questions about how would I know that. You can ask the family, but it's also the kind of thing that you may want to, if the family is enrolled in the health home, you can talk to the health home care manager and also to the Medicaid managed care plan. They should be able to tell you. And this is, there are 3 slides here that show some of those combinations. And again, these you can't absorb this quickly, but these will be posted, and it's also in the billing manual for the children's services. 2 tools to share with you. One is the Managed Care Plan Matrix. This is a document that's updated regularly to include contact information for lots of different people in each of the Medicaid managed care plans, so hopefully you can get to the right person to answer your question in a timely way. Also, the billing tool, which is kind of a live interactive tool that goes over the same form we've been talking about today. When you hover over different fields, it provides you with information about that field. The billing manual, this is for the children's behavioral health services. That can be accessed through this link. Also, a whole set of documents that we maintain the most current version of, or links to the most current versions on the CTAC-MCTAC website, and there's a link there for that. This is some information of some mailboxes for places that you can send your questions or concerns to folks at the state level. The state has asked us to encourage you to reach out to them anytime you have a problem, but also to, when it comes to claims denials or claims questions, to really start with the plan first, because that's where you're most likely to get the most helpful information. But obviously, if you encounter a barrier, please use these mailboxes. And then if you have questions that occur to you after this webinar, obviously you can email us at CTAC and we'll try to get them answered. So Boris, what are you seeing in the Q&A?
All right, so we do have a number of questions, and please feel free to submit questions as they occur to you. All right, so here's the first question is, how are clients assign a patient control number if they do not have an EHR? Really good question, because EHRs will generate that electronically. So I'm going to try to go way, way back in my head before the EHR days of my life. So I do remember, in old days, I guess you would say, where it was a manual process. I remember assigning, numbers, and somebody would keep track, and you would put it on the charts. It was paper charts, and you would say 1, 2, 3, 4. A lot of folks didn't use kind of the patient control number or patient numbers in that instance when they were paper, but you can do that manually, if you will, right, without any electronic systems from that end. What I would also suggest, one way, to kind of bypass, you can actually use either the Medicaid number or the insurance number as your also patient control number. Sometimes with maybe some sort of additional letter or additional number to that. But there is really no great answer to this because it's not electronic, right? Whereas an electronic system will automatically generate that type of a number. But thank you for that question. The next question was field 4, second digit. None of these really fit. Community-based non-clinic providers. Choosing clinic doesn't fit, but it sounds like the best option. Is that correct? That is correct. I'm not here to tell you that that's the one you need to use. It's really for each organization. What again would also recommend you have this conversation with the managed care plans to see how they have identified you in their system and have that conversation with them as well. Sometimes it's very erroneous, and you know, if you're not a hospital, which I suspect most of you are not, and they tag you as a hospital, you can identify that for them. But at the same time, maybe there is some mutual ground. But clinics seems to be in my, you know, kind of when I go around, it's kind of the most common one that people are using, even though, again, understanding that a lot of folks here are not clinic or might not be providing clinic services online. Then there's another one, field 4, third digit. You suggested that many behavioral health organizations choose 7, which is a reserved number. That is okay. Actually, thank you for that question. If I did say that, that would not be okay. I hopefully was referring to field digit, the second digit. So when we look at the second digit, it's field 7 that talks about clinic in that instance. And after that, where you would use is really digit 3, and that would be number 6, community mental health center, if that fits best for your organization. So thank you for that, and you know, making sure that we clarified it. But it's really the second digit where, again, the previous question had the same you know, point is clinic. But once again, just want to make sure you in communication with the plans to make sure that's how you identify and that's the best fit. We have another question around field 17, discharge status. Which do we choose if they are leaving our programs but still receiving services from another agency? That's a very good question. So again, field 17 are not required for all. Let me just go back there for a moment. Maybe, Ann, I think you have the ball.
I
so maybe
do. Oh, sorry. Here, yeah, let me put you back there. I'm sorry about that.
I just want to kind of, hopefully nobody's getting motion sickness.
Seasick, yeah.
Yeah. So we're going to field 17 just as a reference point here. There we go.
There we go.
So again, the patient discharge is not required except for, you know, a number of plans like WellCare, you know, Emblem, Empire, Salus, and so forth. You know, I think you might want to touch base with them, but I think what you want to indicate it is a discharge because they are discharged from your organization. So they're not getting care from you. It's about you at this particular moment, but it's not really fits that profile. And again, these are just some common codes. There is a list of other codes that are available, and you might want to talk to the plans to see if there's other codes that might fit that particular scenario, you know, in the way, you know, they're treating this. So you might want to touch base with them on that. And again, just making sure that, you know, it's only related to those particular plans. We have another question about a clearinghouse. It says, is it recommended to use a clearinghouse? I don't know if recommended is the right term. I think for each organization, they need to determine what's the best way to bill, you know, for now and for kind of strategically planning for the future. I think as Ann mentioned early on in the presentation, for a number of providers, paper claims currently might be the right approach because of volume or other reasons. Moving towards portals, moving towards clearinghouse might be a stepwise direction, but I think each organization needs to evaluate the best approach. And there is clearinghouses, but there's also billing software vendors that specialize in billing and providing billing support. That's not technically clearinghouses. And there's EHRs that also provide billing solutions, even though they also can give you a full comprehensive. So I know it's not probably the answer you were looking for in regards to yes or no, but it really is based on each organization and their needs at the moment and what you're looking for strategically to go forward with that. And we have also a question on field 15. What does point of origin mean? So, Anne, if we can go a couple of fields back, okay. So point of origin, again, point of origin could mean actually a number of things depending on the codes you use. That's why for a number of plans it's not required, except for, again, the ones we indicate here. I would really discuss with them because there are a number of code systems for field 15 that approach point of origin, and some of it is how you got the referral and how you obtain the individual into your care. There's other codes for this field to indicate that. There's also a code system in regards to, you know, in your own organization where the services are provided. For a lot of times, this is really for inpatient and hospitals and emergency rooms, but for some of the plans, they do require even for the outpatient services. So I would really touch base with them in regards to what codes they would accept and what they're really looking for in this particular instance. And so let me see if any, there's a question on how would you send a primary EOB explanation of benefits electronically to the managed care plan? That's an interesting question because usually the EOBs would come to you from the managed care plans. So electronically would mean if they are sending it back to you electronically, it would have to be through a secure electronic communication system. And if not all, most of the plans have that capability where you get a notification that the EOB is available. You have to log into a particular system, and then you can get that EOB electronically from them. So there are electronic means, the way they can communicate with you, that are HIPAA, you know, compliant and so forth, and you can obtain those claims, those EOBs, electronic explanations of benefit. So I think we're at time. And any last words or comments?
No, I just think that the most important thing here is to, you know, dive into this with a team and really carve out some time to look at the results of your claiming efforts early and often so that you can problem solve those quickly with the plans. And, you know, with that, you'll gain some experience and you'll get less of that as you go along. So you can expect a little bit of it in the beginning, and most of those issues can be addressed. But just to really monitor it, I think is probably our most important piece of advice here.
Excellent. All right. Thank you, everybody.
Right. And thank you, everybody.
For joining. All right. Take care.